This is the case study of Mr. Young by JanelleCiccotelli. Mr. Young came into the emergency room from home with a chief complaint of, "I was sitting on the couch at home about an hour ago when I started having trouble thinking and speaking. My right side is also weak." While in the emergency room, the patient was still having a hard time finding his words. His initial vital signs were his blood pressure was 160/97, his heart rate was 72, his oxygen was 99% on room air, his temperature orally was 98.8, and his respirations were 16. Mr. Young is a 46-year-old Caucasian male weighing around 200 pounds. He has a history of hypertension, hypothyroidism, coronary artery disease, tobacco use of smoking a half a pack a day, history of cocaine use, ischemic cardiomyopathy with an ejection fraction of 25%, COPD and he does not wear oxygen at home, anxiety, and GERD. His surgical history includes cardiac stents. His family history is negative. His review of symptoms were all within the normal limits, and he doesn't have any known allergies. Some of the tests that were ordered was lab work, a CAT scan of the head and neck, which was unremarkable, and then he will also be going for an MRI to rule out any other issues. He will also be admitted to the stroke floor of the hospital. Here is an overview of Mr. Young's lab work and medications. As you can see, his potassium is low and his PTT are low. Here's a list of his medications. He is also prescribed aspirin 81 milligrams daily that he states he has not been taken. Based off of Mr. Young's chief complaint, background, lab work, what do you think his disease is that he came in with? Mr. Young was diagnosed with an ischemic stroke. The primary lesion of ischemic stroke is cerebral infarction with an adequate supply of blood to cerebral tissue. The signs and symptoms that you can follow is the acronym FAST, such as face drooping, arm weakness, speech difficulties such as slurring, and time to call 911. Other signs and symptoms can include weakness, numbness or tingling, confusion, or a severe headache. In this case, it was diagnosed by an MRI. The MRI results were positive for acute infarct in the left posterior parietal lobe, which was compatible with minimal hemorrhagic transformation. An embolism is the most common mechanism of stroke. The great majority of emboli are blood clots generated from the heart due to cardiac disease. Such in Mr. Young's case, he does have a history of cardiomyopathy and hypertension, so this puts him at risk for a stroke, along with other things such as smoking a half pack of cigarettes a day. Also, according to Power 2020, the current guidelines for giving intravenous adaplase has shown benefit for patients with disabling stroke regardless of the NIH score. But it is not recommended for those with an NIH score of 0 to 5, which I will go over in the next slide of Mr. Young's NIH scale. The NIH stroke scale is a widely used scoring system to assess neurological deficiencies in patients with an acute stroke. Health professionals use this scale to measure neurological function and deficits by asking the patient to answer questions and perform tests. The checklist of questions and tasks scores a person's level of alertness and ability to communicate and perform simple movements. As you can see to the left, there is the scale of every test that the patient needs to do. Upon coming into the emergency room, Mr. Young had an initial NIH done, and it was a score of 4. The patient was marked for severe aphasia, which was 2 points, 1 point for incorrectly stating the month, and another point for a drift in the right arm. When Mr. Young had arrived to the stroke floor, his NIH was 0. Here is a visual of a stroke occurring from the American Stroke Association. As you can see, the blood is flowing through the coronary arteries, and then a blockage starts to occur. As a blockage starts to occur, it creates a clot that gets dislodged and goes up into the brain, where the oxygen is then cut off. Mr. Young was put on aspirin daily and started on clopidogrel daily as well to help prevent blood clotting. The patient's blood pressure medication will also be held for 24 hours to maintain blood flow to the brain. Mr. Young will also continue the atorvastatin that he was on. Statins are effective in preventing vascular disease and are widely recommended and used for the secondary prevention of ischemic stroke. According to Powers, dual platelet treatment should begin within 24 hours. The patient having high blood pressure may protect the brain by maintaining cerebral perfusion when autoregulation is partially impaired. So the current guidelines suggest that the patient should not be on any blood pressure medication for at least 24 hours. Other treatment in some cases may include physical therapy, occupational therapy, to help with weakness and leftover effects from the stroke. It can also help with their ADLs and then speech therapy as well for aphasia and stuttering. Mr. Young fortunately does not have any residual effects from the stroke. His prognosis is very good. Some education that he can be taught to prevent another stroke from happening is that he should know what caused his first stroke. He should be able to manage his high blood pressure, control his cholesterol levels, be active, such as taking walks every day or even just going to the gym, eat better, have a healthy diet, lose some weight, stop smoking, take his medications as prescribed, or he can even join a support group or a program that can help him aid in exercise and nutrition.